Hello guys, welcome to Arborvitaenxt. Today we are going to discuss about a very important topic from anesthesia point of view, that is known as capnography. Basically, capnography, it means it's measurement of carbon dioxide in expired air. That is the basic thing what is being done here in capnography. So let's begin. So before we go into further details, what are the basic uses for capnography? Why we do it? So capnography is basically used for surest confirmation of endotracheal intubation in various procedures. So capnography is surest confirmatory method of endotracheal intubation. Secondly, in case of sedation and analgesia, there is always a risk of respiratory depression, and we have to detect this very early. So this early diagnosis of this respiratory depression can be achieved with the use of capnography. Thirdly, in case of cardiac arrest, when you give CPR, we can use capnography as a reliable index of effective heart compressions. In this case, the capnography will see with effective heart compressions, the CO2 levels should be more than 10 millimeters of mercury. It signifies their CPR is having effective heart compression. The next use case, that is during any kind of cardiac or pulmonary diseases, we can use capnography to diagnose that, like obstructive pulmonary disease, pulmonary embolism, heart failure, shock, these conditions. Apart from that, we can also detect metabolic diseases like diabetic ketoacidosis. Then, in case of traumatic severe injury, this end-tidal carbon dioxide will be less than 30 millimeter of mercury. Has been found to be associated with increased risk of traumatic severe injury. So what is the basic principle behind this? So the basic principle is, when we pass infrared lights to the carbon dioxide molecule, it absorbs a certain wavelength of light, that is 4.26 micrometers, and it vibrates for a time, and then the next moment it emits the infrared radiation again. So the basic principle is, if we pass 4.26 micrometer wavelength infrared light through the carbon dioxide molecule, if it is present there, definitely we can put a sensor and record the emitted infrared amount, and we can get an idea about the amount of carbon dioxide present in a particular chamber. So that is the basic idea how it works. So now let's talk about uh, the basic capnography circuits. So there are two types of capnographic circuits that are used. One is mainstream, another is side stream. So as the name suggests, mainstream, the sensor for this infrared, we can see here if you look properly. So this is the infrared source. So this is the infrared source which emits infrared light, and this is the chamber, and this is the infrared detector. So this is the mainstream circuit, where the endotracheal tube of this patient is directly connected to this chamber, and directly it measures the concentration of pressure of carbon dioxide, and directly it measures the end tidal carbon dioxide from the endotracheal tube. So you can see there is an electrical cord from the detector which goes to the display, and the carbon dioxide level is computed here. Whereas in case of side stream circuits, you can see this is the endotracheal tube, and the sensor and display is totally different and away from the endotracheal tubing. So there is only one sampling adapter, and instead of where we are getting sampling tube through which the gas will go to the main sensor and display. So this is side stream circuit, where the main sensor is away from the main circuit. So what do you think, which one is the most accurate measure? The most accurate measurement will be given by this mainstream sensor. It's more accurate, no doubt, because in side stream sensor, through the sampling tube, the gas is moving. So this by this time, the temperature and the pressure will be changing inside the tubing and also inside the sensor. So there will be definitely a variation of the exact value. So the most accurate method is the mainstream sensor, that is often they are bulky in nature. So in practical life, in short procedures like anesthesia and anesthesia monitoring, then we use the side stream sensor. So this capnography value basically depends on three variables. So these three variables are metabolism inside the body, because body produces carbon dioxide in the peripheral tissues. So if this is a lung, so peripheral tissues having cells, they will produce carbon dioxide by the process of respiration, that is a part of metabolism. And this carbon dioxide through the blood will go to lungs, and their are there, and this alveoli will get the carbon dioxide out of the body. So the next variable which is most important is ventilation. So the value of the capnography also depends on ventilation. And third, because the blood carries the carbon dioxide to the lungs, so perfusion of the lung tissue, that is also another factor. So depending on these three variables, anything changes between these three will definitely affect the value of capnography. So now let's see the normal capnography curve, how it looks like. So this is a normal waveform of capnography. This. So there are several phases of normal waveform. So there is phase 1 where the carbon dioxide is just getting out of the alveoli and is getting detected by the sensors in the capnogram. There is phase 2 where the maximum amount of carbon dioxide has been already excreted, and it forms a like a plateau, that is known as phase 3. And the phase 4, or it is also known as phase 0, is the rapid decline of carbon dioxide level as the next breath or inspiration begins. So this is a normal waveform of capnogram. So in capnography, you see this is the basic arterial carbon dioxide pressure, and this is the end tidal carbon dioxide. So there is always a gap, and this gap is known as the alveolar dead space. Now, so there are some phases I have told you already. So 1, 2, 3, and phase 4 or phase 0. So there are two angles also. One is alpha and another is beta. So basically, when we say the end tidal carbon dioxide, we actually refer to this point, phase 0. So now let's see some capnograms. This is a capnogram showing the phases of apnea. So you can definitely see initially there were some normal capnogram going on, and then slowly the level of carbon dioxide that came down, and there is no more respiration or no more detection of carbon dioxide. So this is pure apnea. So this is a capnogram showing hypoventilation. You can see the breathing rate is really slow here. This shows bradypnea. So you can also see the breathing rate is also slow here. This is hypocapnia, where the carbon dioxide level and tidal CO2 is really less. You can see it doesn't go up much. It's below normal. This is hyperventilation. You can see how fast the respiratory rate is. So in case of obstructive lung pathology like bronchospasm, there will be shark fin-like appearance of the capnogram. You can see here. And here the phases are like this: phase 1, phase 2, and phase 3. And this is phase 0 or phase 4. So you can see the alpha angle is almost changed totally, because in obstructive pathology, the carbon dioxide cannot come out of the lungs initially. So the slope is totally lost. So we cannot even tell the transition properly, where the phase 2 is, where the phase 3 is. So this is a capnogram of bronchospasm, such as asthma. You can see the shark fin-like appearance. In case of expiratory valve malfunction, you can see this kind of capnogram that you can see. There is no gap in between them. It's a continuous type. Once the inspiration starts, before it totally come back to the 0 level, it again starts expiration. So it's a continuous graph, you can see. This shows inspiratory valve malfunction. It is also continuous, but in this case, the expired carbon dioxide levels are pretty low, you can see. This graph shows a pregnant lady under general anesthesia. It is a normal physiological finding, you can see here. In patients where muscle relaxants are used, we can see this kind of cleft when the muscle relaxant effect begins to subside and the patient makes effort to take inspiration. This time we can see this kind of clefts. They are known as curare clefts. This is a graph showing rebreathing phenomena. So you can notice the graph eventually goes steeper slowly. So this is a graph showing rebreathing phenomena. What are the possible causes? Faulty expiratory valve, inadequate inspiratory flow, insufficient expiratory time, or malfunction of the carbon dioxide absorber system. So this is how rebreathing looks in the real time. This is a graph showing esophageal intubation. If endotracheal tube is by mistake placed in the esophagus, this is how it would look like. This is a graph showing spontaneous breathing by the patient. So it will look like this. In case of single lung transplant, this is how the graph looks like. In case of malignant hyperthermia, you can see this kind of capnogram. In cardiac oscillations, you can find there are oscillations in the phase 4. So in the system, there is some soda lime or carbon dioxide absorbing material. So if that is exhausted, it will look like this, almost similar to the rebreathing. This is intermittent mechanical ventilation graph, where there is spontaneous breathing and intermittently there is a mechanical ventilation occurring. In case of cardiopulmonary resuscitation, we can see this will be the graph looking like. So here is a real-time picture of effective CPR. And after the CPR is being performed, if the spontaneous circulation returns, so we will see the effective CPR is going on and see effective circulation. So that is the return. This point you will see this is the return of spontaneous circulation. This graph is a special graph which shows rebreathing during inspiration in Bain or Mapleson D circuits. It will look like this. Thank you for watching. Please subscribe to the channel for more videos.